You look at your first patient's chief complaint and you realize it says rash, and you wonder, is it a febrile rash that I need to be really worried about? It's not just measles that's out there that's scary, but there's also, what was it? Rocky Mountain spotted fever?
And interestingly, the second chart you pick up is also a rash, but once you see the patient, you actually realize it's petechiae. And this is a toddler who has been more fatigued and less playful. And you wonder, is this something infectious or something more insidious like a new malignancy?
In this episode of Critical Decisions in Emergency Medicine, we will talk about Rocky Mountain spotted fever, specifically the diagnosis and management.
We will also talk about pediatric oncologic emergencies and how they present and their potential complications.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the January 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the critical procedure, critical ECG, as well as our listeners know, one of my favorite, the literature review.
So for our first lesson of today, we have In the Thicket, Rocky Mountain Spotted Fever. Thank you to Doctors Emily Kugler, Tatum Stauffer, and Carlos Rodriguez for writing this article.
So up until today, I thought that Rocky Mountain spotted fever is when you have spotting, like a rash, and fever from a tick that bit you while you're in the Rocky Mountains. I guess that's not the case. So maybe let's review geography first then.
That's a really good point, and I don't think I'm the best person to help with that. But apparently, the highest disease incidence occurs in the southeastern and mid-Atlantic United States. And that is not necessarily where the Rocky Mountains are. And that's why it's a misnomer. And we're going to talk later a little bit more about how the whole rash and fever thing is not really 100%.
Okay, so just spotted fever.
No, it's not either, actually, but...
Okay, we're going to come up with a new name for this. But I guess in terms of a micro review, let's start with that, the facts that we know.
So the causative agent is Rickettsia rickettsii, which is, it's an easy name to remember, right? It's as if your name is like John. It's a pleomorphic gram-negative bacteria that's carried by vectors. So the vectors are the ticks, and that's why we talk about this the whole time. The Dermacentor, which is the Rocky Mountain wood tick, and then there's the American dog tick, the brown dog tick, and there's a lot of zoonotic hosts as well, like deer, rodents, horses, cattle, cats, dogs. So basically just being outside really is a problem because rickettsia in general have been identified on every single continent except for Antarctica.
Another plus for Antarctica then.
Here you go. And interestingly, too, is that half of the people infected recall removing a tick in the past 2 weeks. That's it. Half.
Interesting. So what are the clinical symptoms then when patients present?
So after 2 to 14 days of inoculation, patients are going to have these non-specific viral symptoms. But then 3 to 5 days after the symptom onset, you have the rash. And it starts distally, so hands, feet, wrists, ankles, and spreads centrally to the palms, soles, and trunk, which is why we always say with Rocky Mountain, the classic quote-unquote rash is that it covers the palms and soles. However, a little bit more than half of the patients only will have it on their palms and soles. Almost 40% won't. And 15% will not have any cutaneous manifestations whatsoever. And 15% will never have a fever. So yeah, it's not the Rocky Mountain and it's not spotted and it's not a fever, but here you go.
Great.
The problem as well is that patients have multi-system vasculitis that affects many organ systems. And that is what gets them very sick. And there's a great table that summarizes a lot of these abnormalities in the article. So basically, when you have someone who is ill in an endemic area during the peak seasons, which are your summer and spring, then that's when you should suspect it, irrelevant of the actual specific symptoms.
Got it. All right. Definitely tricky, but if it's on your mind as part of your differential, how can laboratory tests help us?
So the definitive diagnosis is serology testing using direct immunofluorescent antibody, or IFA, from paired acute and convalescent serums as a reference standard. And a positive test takes like 7 to 10 days after disease onset. A negative is not sufficient to rule it out, and the positive just confirms disease exposure but not actual active infection. And therefore, it's really a clinical diagnosis. If you have a patient in an endemic area during a time for ticks, which is spring or summer, who's coming in with non-specific viral symptoms, just ask yourself for a second, could this be Rocky Mountain spotted fever? And there are other tests that you can use other than what we talked about, and they're summarized in the table in the article. But again, at the end of the day, it's a clinical diagnosis.
Okay. So let's say you made the diagnosis. How do we treat it?
Tetracyclines, specifically doxycycline. So really not that difficult once you've made the diagnosis. In non-critically ill adults, it's 100 milligrams PO twice daily for 5 to 7 days. In the critically ill, there's this higher dose regimen where you use higher dose IV as a loading dose, which is really kind of a style thing because there is not really much data to support that, but that's what people do.
All right. But what about the pediatric population? Do we still use doxycycline?
So we use weight-based doxycycline, and I don't know, Wendy, if you have the same recollection from med school that I do, where it's like, oh, you shouldn't really be using it in kids below 9 because something that has to do with their teeth. But that's really just like the old school other tetracyclines. And the American Academy of Pediatrics says that we should use doxy for all rickettsial diseases in children of all ages. So basically, that was made up and took up brain space for no reason.
Huh. All right. But then what about the pregnant patients?
Well, let's keep talking about made up science limiting our care. So, doxycycline in pregnancy is actually safer than previously hypothesized. And still, it's classified as pregnancy category B because it's just technically a tetracycline. And the funny, concerning, confusing thing is the CDC mentions chloramphenicol as a potential alternative for Rocky Mountain spotted fever in pregnancy. But it's clearly not something that we should be using in the third trimester because of something called the gray baby syndrome. So, long story short, it's still doxy, but you need to counsel the patients because technically on paper it is category D in pregnancy.
I see. All right. So what about complications from Rocky Mountain spotted fever? What should we be looking out for?
So, without treatment, Rocky Mountain spotted fever has a 25% mortality rate. That's 1 in 4. That's really high, and even higher in peds. It can be complicated by sepsis or septic shock, just like any other infection. And then, really, the problem here with the whole vasculitis is that you have increased vascular permeability resulting in edema. And the rash itself can progress to like more severe vascular damage, resulting in frank hemorrhage at the center of the lesion itself. They can have acute kidney injury, hypovolemic shock, symptomatic hyponatremia, CNS involvement, usually in the form of encephalitis, non-cardiogenic pulmonary edema, ARDS, platelet consumption causing thrombocytopenia. So basically, a lot of badness. So definitely worth thinking of it early in your patients and treating them if you think they have Rocky Mountain spotted fever.
Got it. Well, thank you, Danya, for taking us through this lesson. There are, of course, a lot more pearls in the lesson that everyone should check out. I think to start, as you mentioned, the name is somewhat of a misnomer as the highest incidence actually occurs in southeastern and mid-Atlantic United States. So you need to have a higher suspicion of this disease, especially in the spring and summer times when patients are presenting ill, to consider it as part of your differential. We also talked about how the clinical presentation is really variable. While fever and rash can occur and classically described as macular lesions on the palms and soles, obviously not every patient can present with that. And some even don't present with any cutaneous manifestations. The big thing to consider is that they can involve multiple organ systems because it is a vasculitis type of process. So again, need to have it on your differential. And if you're concerned, you can send serologic testing, which confirms disease exposure, but not active infection. Now, in terms of this clinical diagnosis, if you're concerned, treatment is with doxycycline with adults, as well as with pediatrics as supported by AAP recommendations, and also with pregnant patients, except that we need to counsel them because it is technically classified as a pregnancy category D medication. It can be associated with severe complications as up to 25% mortality. And again, multi-system involvement and multi-system dysfunction, whether it is hypovolemic shock, CNS involvement like encephalitis, ARDS, DIC. So patients can present definitely quite sick. So this is a very good opportunity to review this topic so that we can better take care of these patients.
Great summary of a great article. Thank you, Wendy. So for our critical ECG this month, it's this incidental finding on an ECG, and it's a great reminder of what it means to say sinus rhythm. So, Wendy, if you have an ECG where the P to QRS ratio is 1:1, and it's a normal rate, then it must be sinus rhythm, right?
I guess not.
And that's exactly what this lesson is about. Now, if the P wave is inverted in leads 1, 2, and 3, or if the PR is shortened, then you need to think that this might be an ectopic atrial rhythm, which is what this patient had. The rhythm has a supraventricular origin, and the focus is outside of the SA node. And if they are lower in the atrium, so closer to the AV node, they're inverted. But if they're higher, so closer to the SA node, they look upright. But your clue here is that the PR is short. Now, is it scary? Usually not. The cause is really just an increased vagal tone. So, somebody's young, athletic, sleeping, in a lot of pain, actively vomiting. But there are other things that can cause that. So medications, electrolyte abnormalities, some conduction abnormalities, myocarditis. So if the patient is asymptomatic and you see this, nothing to worry about. But if they're having some symptoms like dizziness, syncope, something of that nature, then you need to look into their electrolytes, review their meds, make sure that they haven't ingested anything else outside of their meds. And if there's no clear answer for that, and again, they're very symptomatic, they may need a cardiology consultation for an ambulatory cardiac monitoring.
A very good reminder. For our clinical pediatrics this month, we have a case of an 11-year-old presenting with eye redness that has been worsening. And you learn that the patient has autism spectrum disorder and is an extremely picky eater, which will be relevant as we talk about the case. On your exam, he has existing poor vision with corneal opacity, and he also appears to have some photophobia on your exam. Ultimately, you do get ophthalmology involved because of the complexity of his ophthalmologic history and presentation, and they find that he has foamy white plaques in the conjunctiva as well as corneal ulceration.
So I don't know about you, Wendy, but when patients come in and ask me to check their vitamin levels, I think it's just really not what we do, except when your vitamin A deficiency presents like this. So apparently vitamin A deficiency disrupts the corneal epithelium. And that's when we have white epithelial lesions known as Bitot spots that can form. Patients can have corneal or conjunctival xerosis, corneal scarring, ulceration, perforation, and eventually vision loss. So that's pretty concerning. Patients can also have non-specific dermatologic manifestations such as dryness or amelia, and they may also have other organ system involvement such as GI symptoms or respiratory symptoms, because then they're susceptible to malnutrition and infection. Now, it's quite rare in resource-rich countries. However, if a patient has a malabsorption disorder like cystic fibrosis, celiac disease, irritable bowel disease, bariatric surgery, then even though they are receiving that appropriate nutrition, their body may not be actually getting what it needs.
While this was a case of vitamin A deficiency, it's important to remember, of course, when patients are presenting with corneal opacities, it could also be related to infection. And we have to think about chlamydia as a potential source causing chronic inflammation and scarring, as well as other risk factors for general other organisms such as contact lens use, trauma, and such, which can increase your risk of pseudomonal infections, staph infections, etc.
Definitely an interesting case. So, our literature review this month is the 2025 AHA guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, which was published in Circulation in 2025.
We're certainly very familiar with resuscitation in cardiac arrest across different patient populations, but I think it's always a great refresher. And a few changes that we need to think about are that in neonatal resuscitation, now the AHA recommends delaying cord clamping by at least 60 seconds, and that a supraglottic airway device can be a useful adjunct if needed for airway management in neonates as well. As for pediatric life support, it is no longer recommended to use a single hand, two finger technique. Instead, we want to use the two thumbs encircling the torso technique. And that if you're worried about foreign body airway obstruction, you want to give 5 back blows followed by 5 abdominal thrusts and repeat as needed until the patient becomes unresponsive or the object is dislodged. In adult life support, we do provide the same approach in concerns about foreign body airway obstruction. As for the actual CPR component of things, if you have access to a real-time feedback device during CPR, that is good in ensuring that we're providing high-quality CPR. But mechanical CPR devices is actually not recommended except in instances where we cannot provide high-quality manual CPR. Specific to cardioversion for arrhythmias, the recommended starting energy is now 200 joules. And then, as we are all familiar also, if we're dealing with a pregnant patient who are presenting a cardiac arrest, then we should utilize the lateral uterine displacement when we assess and find that the fundus is above the umbilicus and consider resuscitative delivery within 5 minutes of the mother's cardiac arrest. And finally, if you're successful in regaining spontaneous circulation, now the recommendation for temperature management post-cardiac arrest is between 32 to 37.5 degrees. And don't forget an EEG to evaluate for any concerns about seizure activity or myoclonus.
Great review for a great article that we all should know about. So, our critical procedure this month is bladder rewarming for hypothermia. So we talked about bladder lavage as the active method of rewarming a patient's core, and it is a lot less invasive than a thoracic or peritoneal lavage. Obviously, if you think that if somebody has a traumatic urethral injury, that's not really the way to go. But other than that, it's pretty straightforward. Obviously, you need to be careful with overwarming, just like you would in any other active method. The best way to reduce side effects is to use a sterile technique, warm sterile fluids, and then keep in mind that the rewarming itself, rather than the specific technique, has a lot of side effects, the physiological changes from fluid shifts and electrolyte disturbances.
Exactly. As you mentioned, the technique is pretty simple. Certainly, we're providing other methods of rewarming, such as the environment, etc. But specifically for this bladder rewarming, you want to insert the urinary catheter, instill sterile warm fluid into the bladder, and clamp the catheter, and then unclamp it approximately 10 to 15 minutes later to drain the fluid and repeat as necessary. The other option is to use a continuous bladder lavage if you have a 3-way Foley catheter to be able to do that continuously. If you don't have sterile warm water available, you can use saline bags that you warm up as long as they don't contain dextrose, because if you were to warm it up in a microwave, you don't want the dextrose to crystallize.
Great pearl, do not rewarm dextrose in the microwave. Not something that I ever thought I would say. So our critical cases in orthopedics and trauma this month is a traumatic amputation.
Yeah. This is a 75-year-old man who unfortunately had his right lower extremity amputated, stuck in an auger while he was doing farm work. And so EMS had applied tourniquets, which controlled the bleeding and brought him to your ED. And in your management, certainly provided analgesia with ketamine, but unfortunately afterwards he was intermittently apneic and needed airway intervention. And right after intubation, he became severely hypotensive and actually had cardiac arrest. So several elements here that are worth discussing.
So traumatic limb amputations are most commonly after MVCs or machinery accidents, and it's usually the lower limb, and that outnumbers upper limb involvement by 3 to 1. I guess that's a good thing. Our big things here are like immediate hemorrhage control and resuscitation, assessment of limb viability, and then early administration of IV antibiotics, checking for distracting injury, and pain management. Now, for hemorrhage control and circulatory resuscitation, that can be achieved using direct pressure over the injury with rapid initiation of blood transfusion and tourniquets. And then, as for the limb viability, the assessment would include vascular eval, neurologic eval, and soft tissue eval. Now, the vascular eval can be with like a Doppler ultrasound or by pulse palpation. For the neuro assessment, it would be motor and sensory deficits. And we need to remember that warm ischemic time beyond 4 to 6 hours significantly reduces salvageability. So that's why we gotta act fast. Early IV antibiotics should ideally be administered within 1 hour of the injury or hospital presentation. And then for highly contaminated wounds or wounds with vascular compromise, we should not forget about anaerobic coverage as well.
In this particular case, unfortunately, he had a cardiac arrest in the setting of post-analgesia intubation. And I think it's a good reminder that we often utilize a multimodal approach to analgesia and try to pick agents that may have less negative effects. Ketamine and fentanyl are obviously preferred for some of those reasons. But the other component is that, of course, these patients come in with oftentimes a very compensatory sympathetic drive. And after administration of medications that can cause vasodilation, that can then unmask the underlying hypothermia from blood loss and then lead to the post-intubation arrest that we saw.
So our critical image this month is a case of a 14-year-old boy presents with right scrotal pain that woke him up from sleep. It was quite severe. It got better after ibuprofen, and he had a similar episode 4 months earlier. His exam is notable for a high-riding right testicle with no swelling or tenderness, and the ultrasound shows possible epididymitis but no evidence of testicular torsion. He goes home. He comes back 2 weeks later with the same symptoms. The ultrasound is done then, and what does it show?
This time around, I did confirm that there is no testicular blood flow. And so I think this is a good reminder that the clinical presentation for torsion can definitely have an intermittent symptom and finding, even on ultrasound. And while we're looking for the high-risk clinical features like sudden pain, nausea, vomiting, high position of the testicle, and abnormal cremasteric reflex, if you identify somebody who is high risk, sometimes you may even need to advocate for these patients to undergo surgical exploration and really forego even potential imaging. And utilizing something like a validated score, which is the testicular workup for ischemia and suspected torsion, TWIST score, may help you re-stratify these patients.
An easy name to remember. Now, the American College of Radiology Appropriateness Criteria rates ultrasound with duplex Doppler as usually appropriate, and MRI with or without IV contrast as maybe appropriate. Now, of course, the fastest reliable imaging is favored, which makes MRI unrealistic in most instances, especially since ultrasound is less expensive and more widely available. However, if you're worried about intermittent testicular torsion with spontaneous resolution, which can be up to 50 to 60% of patients who are ultimately diagnosed with acute testicular torsion that requires operative intervention, then you really got to think about that. Now, elective orchiopexy after an average of 2 painful episodes decreases the testicular loss rate to 0%, which is compared to 53% of testicular loss in patients who underwent emergency orchiopexy after an average of 3 presentations. That's a huge difference. And in certain cases, operative intervention without ultrasound may even be appropriate to avoid unnecessary delay in high-risk patients. Now, moving on to our second lesson this month, it's Bag of Tricks, Pediatric Oncologic Emergencies. Thank you to Doctors Elizabeth Collier, Guokang Wang, and Suzanne Seo for writing this article. Now, while quite rare, 7% of pediatric cancer cases are diagnosed in the emergency department. So, emergency physicians must be able to recognize signs and symptoms of common pediatric cancers as well as potential complications associated with them.
Absolutely. The most common pediatric cancer overall is acute lymphoblastic leukemia, ALL, and the most common solid tumor in children are brain tumors, followed by neuroblastoma and nephroblastoma. And so they definitely may be diagnoses we make in the ED as patients may present with acute oncologic emergency like pancytopenia and hyperleukocytosis, as studies have shown that more than three-quarters of these patients are presenting this way.
So, let's start with acute leukemia. When should we suspect this diagnosis?
As we know, acute leukemia, we're dealing with blast infiltration of the bone marrow, as well as extramedullary hematopoiesis sites. And so they are often presenting with leukocytosis or leukopenia, and oftentimes also anemia or thrombocytopenia. And their presenting symptoms, though, to the ED may be fever, malaise, hemorrhagic manifestations, maybe even bone pain, or hepatosplenomegaly and lymphadenopathy. Commonly, we're really suspecting this diagnosis when we see on their CBC circulating blasts, but really the diagnosis requires a bone marrow biopsy. But in the ED, you can help assist with the diagnosis with other tests like a peripheral smear, coags, fibrinogen level, LDH level, as well as even a chest x-ray, because that may also show something like a mediastinal mass.
So, what are some complications of acute leukemia?
Two major ones that we should be aware of are hyperleukocytosis and tumor lysis syndrome. So, in terms of hyperleukocytosis, these are patients coming with a white blood cell count that's greater than 100,000. And this really causes a hyperviscosity syndrome that can lead to essentially local tissue ischemia and hypoxia. The common organs affected are neurologic and respiratory. So patients are presenting with fever, respiratory distress, and CNS symptoms. And hyperleukocytosis itself can increase risk of tumor lysis syndrome. To treat that, we're talking about antibiotics for any febrile patients because of dysfunctional neutrophils and the risk of infection in that case, as well as starting chemotherapeutic agents. Now, the other complication, like I just mentioned, is tumor lysis syndrome. And this is where all the malignant cells lysis and causes a lot of electrolyte derangements that can be quite dangerous, like hyperkalemia, hyperphosphatemia, and elevated uric acid. And of course, that has risk of dysrhythmia, seizures, as well as acute renal failure. If you're suspecting this, you do want, of course, to get your CBC and chemistries, and then also uric acid, LDH level, urinalysis. There is a tool, the Chiaro-Bishop criteria, that can help you make the diagnosis, and that's included in the lesson that we can take a look at. Management is really to try and prevent these complications, which is hydration, using allopurinol or respiricase to help reduce uric acid formation. The one caveat is that if a patient has G6PD deficiency, then they cannot get respiricase because it can precipitate hemolytic anemia or methemoglobinemia.
Got it. So, let's move on to CNS malignancies. When should we suspect those in children and how can we diagnose them?
CNS malignancies, unfortunately, are the second most common pediatric malignancy. And so the symptoms that they're presenting with certainly can be actual neurological symptoms or also more nonspecific symptoms like failure to thrive, irritability, worsening headache, gait instability, etc. And so certainly the red flags we're looking for are progressive worsening headache, morning vomiting, and as well as focal neurological findings.
And what are the complications of these CNS tumors?
Yes, you can imagine the complications include things like seizures or even intracranial hypertension and even in severe cases, herniation from the progressive mass effect and edema. We should watch out for, in very severe cases, Cushing's triad, which is hypertension, bradycardia, and irregular respirations. Remember that bradycardia in the pediatric population may be different than what we're used to in the adult population. So be aware of what is actual normal, right, heart rate for, of course, our peds patients. Treatment, though, include corticosteroids and osmotic agents.
Great pearl. Now, let's talk about intra-abdominal tumors.
Yeah, classically, we're talking about neuroblastoma and nephroblastoma, which, as we may have learned, are Wilms tumors. But these are often presenting with as an abdominal mass involving potentially the adrenal gland for neuroblastoma, but it can also arise anywhere along the sympathetic chain. For nephroblastoma, since it's a renal malignancy, these patients may be presenting, of course, with GU type of symptoms in addition to constitutional symptoms. And they can also present as part of a syndrome, Geiger syndrome, the Wilms tumor, aniridia, genital abnormalities, and mental retardation. And so hopefully, if patients are presenting in as part of that syndrome, that would not be the first presentation and diagnosis we make in AD.
So, what emergencies are associated with the pediatric intra-abdominal tumors?
We think about it in terms of any sort of intra-abdominal process, whether it's bowel obstruction or intussusception. But if you are worried with a patient presenting with either new diagnosis or complications of intra-abdominal tumor, the other consideration is that when you're obtaining the imaging, actually obtaining chest imaging as well after consultation with pediatric oncology, because a new abdominal mass for the concern of possible malignancy can be associated with, of course, metastatic disease, as up to 15% of nephroblastoma cases actually present with metastases.
Well, thank you, Wendy, for going through this article. I've learned a lot about a very sad reality, which is that we will see pediatric patients in our emergency departments and diagnose them with cancer. Our number one would be acute leukemia, and patients would show up with either leukocytosis or leukopenia, and oftentimes with anemia and thrombocytopenia. And it was a great reminder that 80% of all leukemias is ALL, which commonly presents in children aged 2 to 5. So in patients who have unexplained fever, malaise, bone pain, lymphadenopathy, we should get that CBC and preferably a peripheral smear if possible as well, and additional workup if we can, including a chest x-ray. And patients with acute leukemia may either come in with complications from the disease itself, like hyperleukocytosis, cytopenia, coagulopathy, and infection, or from the treatment, such as tumor lysis syndrome, which can also happen just from the disease itself. CNS tumors are the second most common pediatric malignancy. Medulloblastoma is highest in infants and younger children, whereas glioblastoma is in kids above the age of 10. Red flags are progressively worsening headache, morning vomiting, focal deficits, and gait disturbances. And these can be complicated by seizures, intracranial hypertension, and acute brain herniation. And it's very important to remember that Cushing triad, which is the hypertension, bradycardia, and irregular respiration, is something we need to think of in the context of age, because normal vitals are normal for that particular age. And the treatment would be steroids and osmotic agents. As for intra-abdominal tumors, we have neuroblastoma and nephroblastoma. Nephroblastoma is the most common renal cancer in children, and it's usually just one abdominal mass. With a neuroblastoma, it can occur anywhere along the sympathetic chain, but most common primary site is the adrenal gland, so they may have a large mass that crosses the midline. Emergencies associated with that can be bowel obstruction, intussusception, and of course metastasis. So we need to consider looking at the chest as well with imaging if the presentation is consistent with that.
Thank you, Danya, for the summary. So moving on to our drug box this month, it's actually about ketamine-midazolam for pediatric convulsive status epilepticus. As we've certainly discussed in the past, sometimes patients presenting with status epilepticus don't respond to benzodiazepines alone. So there was a study, the KED-MID study, that looked at ketamine as an adjunct to midazolam. In a study, they gave ketamine 2 milligrams per kilogram, max dose of 60 milligrams, plus midazolam 0.2 milligrams per kilogram, versus just midazolam plus placebo to examine their efficacy. And they found that the combination of ketamine plus midazolam did improve seizure control and cessation at 5 minutes. And that group also required lower rates of repeating midazolam doses, as well as even endotracheal intubation, as there were no increases in respiratory depression, hypotension, hemodynamic instability, etc. So it sounds like the combination of ketamine and midazolam may really be a strategy for some of these more challenging to treat status epilepticus cases.
And ketamine again for the win. Last but not least, arsenic toxicity. Now, arsenic is non-poisonous in its typically silvery gray elemental status, but it can form several inorganic salts or oxides of exquisite toxicity. And it typically occurs after ingestion of that inorganic salt and can manifest as prominent GI symptoms and then can progress to multi-system organ failure associated with neurologic, cardiovascular, dermatologic, and hepatorenal symptoms. It can be things like abdominal pain, nausea, vomiting, diarrhea. For cardiovascular symptoms, it can be tachycardia, hypotension, ventricular arrhythmia. With neurologic, it can be delirium, coma, seizures. And then they can have other injuries that are like liver and kidney. And the diagnosis is urine arsenic test. It can either be a spot test or a 24-hour collection. And the treatment for severe toxicity would be to treat with chelation with something called British anti-leucite, IM. So you need to go to England, I'm guessing, or something. It's unclear to me what you're supposed to get that from, but call your poison control center. And then if they're less symptomatic or it's chronic toxicity, then it would be dimercaptosuccinic acid orally 3 times daily. Now, if after the ingestion, the patient had no symptoms whatsoever within 6 to 12 hours, then they're unlikely to develop a severe manifestation. But I think more importantly than this Tox Box, there's this story of the physician that tried to poison his wife with arsenic that got written into a crime story. Did you read that, Wendy? It was actually in the Baltimore area, like in the late 80s.
Wow. Okay, we're famous for other reasons.
Yep. So please look it up or not. But it was pretty interesting. He wanted her money and didn't want to divorce her. So he thought of arsenic. So apparently now we know how to treat that if it were to happen again.
Interesting indeed.
Well, thank you, Wendy, for taking the time to go through this issue with me. I learned a lot. RGL listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and definitely never boring.
Reach out to us on our social media. My handle on Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month.
Bye-bye.